Good morning, PTNI's daily show. Happy Tuesday morning. I hope your day is off to a great start. My name is Alan. Happy to be your host today. Currently have the pleasure of serving as Chief Operating Officer here at the Institute of Clinical Excellence and a faculty member in our fitness athlete division here on Clinical Tuesday. I don't know that I've ever been on Clinical Tuesday. So here on Clinical Tuesday, we talk all things clinic. We talk manual therapy techniques. We talk clinical practice versus the other days of the week where we might talk about leadership, fitness athlete, older adult, or pregnancy and postpartum. Courses coming your way. Again, we have so many. ptnice.com. Check out that geo map. We have over 50 coming your way between now and Thanksgiving. So if you're looking to jump into a course, they're all on there. A couple online courses are starting this week. Rehab of the Injured Runner is starting today, I believe. And then we have the rest of our online courses starting over the next couple weeks for the last cohorts of the year. If you're looking to bring us your way, ptnice.com, click that host a course button. Most of our divisions are well on their way to being booked for 2023. Some divisions are booking into 2024. So if you're looking to bring us your way, you'll find that it's quite cost-effective way to get a course to your clinic, especially if you have a handful or more of practitioners at your clinic. So check out the details on there, shoot us an email, and we'll connect you with all the details. Some other quick announcements here coming your way. We have the Warrior WOD matching campaign going on. It is the last week. It's going to end this Friday, September 30th. We're giving $10,000 to Warrior WOD and matching one-to-one every dollar. Another organization matching one-to-one. So you have a 3-to-1 match going on for your money to donate to Warrior WOD. For those who don't know, Warrior WOD is a veterans organization, a 501c3 charity, where they use their money, 100% of their money, in fact, to use functional fitness. They can't say CrossFit, but they mean CrossFit, using CrossFit memberships and nutrition to help veterans get through PTSD without the need for illegal substances to get through their PTSD. So obviously, as a veteran, I'm a giant fan of Warrior WOD, and we're well on our way to meeting our $10,000 goal, which will turn into $30,000 for Warrior WOD at the end of the match campaign. So check them out, warriorwod.org, learn a little bit about them, click that donate button, and even consider $10. $10 turns into 30. That's a great deal. So check out Warrior WOD. Big thanks to folks in Kansas this weekend. Salina, Kansas. I've been saying Salina. That is incorrect. Salina, Kansas, for having older adult down there. I was down there to watch Alex and Sam teach this weekend. A fantastic group down in Kansas. We had a great time. So thanks to all the folks from Kansas Physical Therapy Partners for having us down. Let's get into today's topic on Clinical Tuesday. How do we sequence manual therapy? We get this question a lot. It's a question that actually just came up very recently in our Clinical Management of Fitness Athlete Essential Foundations class. When do we put manual therapy into the session? Does it come at the front? Does it come at the end? Does it come in the middle? Do you always do it? Do you never do it? How do we sequence manual therapy? If you've been following us for a while, you know it is one of our 3 pillars: manual therapy skilled, psychologically informed, and fitness forward. We do use manual therapy here. We are not an anti-manual therapy, a manual therapy sucks group. We are on the side that manual therapy, while giving us short-term benefits, does indeed help, and we're going to leverage that when we think it will be helpful. Ultimately, of course, moving that person towards the fitness forward mindset, but using manual therapy when we believe it would help. So how do we sequence this? I think we need to step back, and I want to make 3 points today. The first and actually the second are going to be really question-based, and they're going to be questions that you should be asking both yourself as the practitioner and the patient in front of you, both in your clinical reasoning mind, thinking to yourself and asking questions to yourself, but also actually asking the patient some questions to determine if you're going to use manual therapy, when, why, how, and what types of manual therapy you might be using. So the first thing we need to know is, what is the goal of this session? And now that can be a question we can answer intuitively. That might also be a question that we ask the patient, maybe even on their first visit, as we're going through that initial evaluation. What is your goal for physical therapy? Is your goal for physical therapy total and complete pain removal, right? Are you unhappy unless we remove 100% of your symptoms? Or are you okay being in some level of discomfort? And I think you'll find once you start asking that question, some folks are just naturally accepting that life isn't meant to be 100% pain-free and happy and free of any sort of discomfort. And those folks in your head, then you're maybe thinking, I maybe don't need to work as hard. I maybe don't need to use as much manual therapy to calm this person's symptoms down before we can move to load. That if this person is okay with some level of discomfort, maybe we can skip manual therapy entirely and go right to load. We know we have a lot of great research that says pain-free physical therapy, 100% pain-free physical therapy, is the least effective physical therapy treatment. That when some folks are in some level of discomfort, they tend to come out on the other end, not only with better pain outcomes, but with improved objective measures across a number of different domains, including strength, muscle size, things of that nature. That if we're able to get to loading essentially sooner, the patient has better long-term outcomes. But again, we have to meet the patient where they're at. We need to know, are they okay with that? If they are somebody who is not comfortable with any degree of discomfort, then we know we might have to back off a little bit. We might have to do some manual therapy before that person is ready to say yes to get out in the gym to loading. So we need to know, what is the goal of this session? If the goal of the session is decreasing pain, improving range of motion, or improving fitness, then maybe we are considering starting with some manual therapy. What we know now about manual therapy is essentially, especially when you use it at the front of the session, we're getting a lot of muscular activation and blood flow, dry needling, cupping, spinal manipulation, soft tissue, whatever you're doing, you're moving a little bit of blood around. You're probably decreasing a little bit of a pain response. You're probably going to, if only by nature of improving blood flow, improving some range of motion, and that's going to let us get out into the gym and load a little bit more. So if we're thinking those are our goals, then maybe we're thinking that we sequence manual therapy at the start of the session. It makes sense. It's almost like a warm-up. Now, some folks will say, well, why don't you just go warm up? Well, clearly you've never been in debilitating pain, because the last thing you feel like doing when you're in unbelievable pain, when you can't move your own leg, maybe because your lumbar radiculopathy is so bad, you're dragging your leg behind you. The last thing you're thinking about is going into the gym and trying to move. So using manual therapy, calming those symptoms down enough that we can then move that person into the gym. Now, on the other side of the continuum, what if the goal of that session is recovery? Maybe this person is already active. Maybe they are active an hour a day at CrossFit or running or cycling or row house or cycle bar or pure bar or any of the other bars and pures out there that a person can go through. Maybe they're already an active person. Maybe they're even a little bit further than an active person. Maybe they're a competitive athlete, and the goal of that session is recovery. Well, then maybe the majority of that session looks like manual therapy, especially if that is why the patient is coming to see you. If they're already exercising 2, 3, 4, 5 hours a day, then having them come in and do a REMOM or an AMRAP and adding more volume to the equation is probably going to do very little to help what's going on, especially if they're not actually in any pain and they're just coming to you because they're feeling beat up. Hey, I'm really sore. I'm just really stiff and achy and sore. I don't actually think I have anything wrong or an injury. Then that is a great patient that might like to do dry needling for 30 or 45 minutes, that might like some full body cupping or something like that. That looks more like a recovery session. And we need to really be more in tune that is okay. If the patient is requesting it, if we check the patient out and nothing is going on with them, then by all means, take their money to do manual therapy to them, right? We're not harming anybody. They're often paying cash for those services anyways. So there's really no harm in having a recovery session, especially for somebody that's already an active individual. They're already checking the box on resistance training and aerobic training and their regular training. So first ask yourself, what are the goals of that session? And that will naturally create a branch in your mind, a decision tree of where you're going with that session. Are we front loading manual therapy? Is the session going to be more manual therapy based? Maybe manual therapy comes in at the end. Maybe we have that person go spin on a bike. We show them a couple of stretches or mobility exercises that we like for some of their stiffness. And then maybe we finish with the manual therapy at the end. So a couple different ways to take that. The second question to ask, and this is something you're going to dive into throughout the plan of care, but especially in that initial evaluation, is what are the patient's beliefs about manual therapy? Friends, if you're not asking people the other treatments they've had before they've come to see you and what they think will help them, you are missing out on a lot of gold. You're missing out on some hilarious stuff, first of all, but you're also really missing out on what that patient really believes is going on in their head. Asking somebody what they've already had will let them know, well, that's probably not likely to help them in the future if we just do more of it here, right? If somebody says, I have had adjustments 3 times a week for 15 years for my neck pain, well, we have to question, was the right area adjusted? But in general, we're probably thinking spinal manipulation is not something likely to significantly budge the needle with this patient. If you're not asking them what they've already done, you are missing some gems. I had a patient one time who was seeing a practitioner who had her put different types of dirt from all over the world underneath her tongue for her low back pain. So when you meet a patient like that, you're thinking, well, it doesn't really matter what I do. It's all going to be more significantly effective than that. So ask your patients, what kinds of treatments have you already had? And then ask them, what do you think will help you? And I think what you'll find when you ask that question, we're often afraid of asking that question because we believe in our mind, our bias is that all of our patients just want a massage, right? And that if we ask that question, our patients just say, I just want a massage for an hour. But I think if you ask that question, you'll be surprised to find that most people are going to kind of look down at their toes and say, well, I probably need to exercise more, right? Bingo. That is our target demographic. That is a person that doesn't really seem to have a powerful belief in anything manual therapy related. Maybe they've never had it in their life. Certainly, they might not know anything about the specific techniques that you use. And that is a patient that we're probably going to be able to move into the gym much more quickly, combined with the fact of what is the goal and how comfortable are they with some level of discomfort with physical therapy. If they're okay with some low grade pain and they don't have any significant belief about anything manual therapy related, that might be a patient that goes right to the gym, right? That we get started with isometrics, we get started with some stuff to do at home for loading. We move them towards fitness a lot quicker versus there are those people who say, I think dry needling would cure my low back pain. I heard about this cupping thing that I think will help my shoulder. Those are the patients that we need to kind of check ourselves and say, okay, if this person has such a strong belief that this will help them, then not doing it is probably going to harm some level of this therapeutic alliance. There's some really interesting research, especially if you read the methods of almost any paper that looks at physical therapy versus anything else. You'll find that a lot of the patients drop out of studies because they weren't getting manual therapy. You'll find a lot of patients are dropped from studies from the researchers because the researchers find that when that person left the study, if they were not in a group that received some sort of manual therapy treatment, they often went and got more physical therapy or maybe chiropractic treatment after their research appointment at a different clinic in town. So they went for an hour where they maybe did exercise only and thought, well, it'd be great if I got a massage or some cupping or some needling. And they went and had more therapy down the road after the study. And of course, that's going to confound the study. And those people either drop themselves out or are dropped out. So again, if that person has the belief that it's going to help them, we should probably at least do a little bit of it. But that comes with a lot of responsibility on us to make sure that if we're going to do it, that brings me to my third point, that we are objective with it. That before we do it, we have collected some subjective and objective asterisk signs that we're going to test against when we do some manual therapy to see if it actually helps or not, right? We're going to measure that shoulder flexion that's at 150 degrees. If we're going to dry needle the lats and subscap, afterwards, we need to reassess that shoulder flexion and say, okay, we got 30 degrees. We know the area that we targeted for treatment is the area we need to work on with exercises to reinforce this. And if that person comes in 150 needle, 150 didn't work, we saw no change, we need to be humble and think, okay, maybe manual therapy for this person is not going to be as effective as I thought, and we need to move on. I love what Tim Flynn said very, very long ago now, almost 20 years ago. Move it, then move on, right? Don't think too much about it. If you assess and it helps, great. Ride it until it bucks you. If it doesn't help at all, move on to something else, move on to exercise. So be objective. If it helps, keep it up. If it doesn't help, try something different or try to go just to exercise. So thinking about sequencing manual therapy, what are the goals of the session? Are we trying to reduce pain? Are we trying to improve range of motion? Are we trying to improve fitness? If so, we might be thinking about trying some manual therapy at the start of the session. Is the goal of this session recovery? Has this person come specifically and said, I am looking for some recovery work? Then maybe the session looks mostly like manual therapy or has maybe a lot of manual therapy at the end of the session. What are the patient's beliefs? Have they had anything manual therapy related in the past? Do they have a specific belief that a specific manual therapy technique might help them? If so, we should probably at least try it, but we should always be objective with what we're going to do. Did it actually create a change? If it did not, we need to let it go, that using our hands might be the way to help this person. And finally, I just want to touch on the idea that manual therapy should be some sort of reward for coming to physical therapy. My personal belief is I couldn't believe less than that, right? If you don't want to come here, you don't have to come here. I'm not going out in town with a van and putting a gun to people's heads and making them come to physical therapy. They are coming here voluntarily. We do not trade exercise for a quad massage afterwards, right? Remember, at the end of the day, you are not a slave. You are an independent healthcare provider. You don't have to provide any treatment you don't want to. You don't have to end every session with soft tissue massage. That is just going to create an environment of people depending on you and believing they deserve that versus teaching those people how to manage their own symptoms with self-treatment at home. Manual therapy techniques they can do at home. If you have a Theragun at home, do it to your heart's content, right? But we're not going to do it here. We'll be focused on stuff that gets you better and give you maybe some of that stuff for home for you to do on your own time. But when you're here, it's an hour. We have an hour to get a lot done, and we want to get as much done and be as effective with our time as we can. We don't end every session with a massage just because the patient tries to negotiate and hold you ransom for manual therapy at the end of the session if they come in and do 30 minutes of exercise or so. So just keep that in mind as well. We don't have to do it just because the patient requests it. We ultimately guide the treatment. And at the end of the day, we don't have to treat somebody, right? We have the pleasure of working with people. They have the pleasure of working with us. It's a two-way street. We don't have to do it just to get a manual therapy unit on the billing sheet for the day. So keep that in mind as well. So I hope this was helpful. I'm happy to hear any discussion or comments you all have about this. Feel free to throw them over on Instagram, or you can email them to me, info@ice.physio. I'd be happy to hear them. Other than that, I hope you have a fantastic Tuesday. Please, again, check out Warrior WOD and have a wonderful week. Bye, everybody.